So, what's really interesting? I've been, you know me, I'm a huge nerd.
Yes, part of the
We've,
reasons I
yeah,
love you.
yes.
Yeah.
And so we know that that was my nickname since childhood is nerd,
Mhm,
right?
mhm.
But I've been reading about this latest data from Eli Lilly on their phase two data, and in the summer, their phase three data will be coming out
Mhm.
about their medication. It's known as Zepbound, but ironically, Zepbound and Mounjaro are actually the same drug from Eli Lilly.
Mhm.
It's just that one has an indication for weight loss and the other is for diabetes. So Mounjaro is for diabetes, but
Right.
Zepbound is for treatment of obesity. They studied this drug now in obstructive sleep apnea with a primary indication for obstructive sleep apnea. And
Mhm.
so this new study is giving a suggestion, a very promising one, that it will be a treatment that probably will get approved.
Yeah, I know that we've talked on the phone about this. There was a Oprah Winfrey special for our listeners or people who are watching this, that came on, and Ash and I were very interested in it. As you guys know, I'm into health and fitness. I've had a lifelong struggle with weight. I choose to eat a certain way, exercise. And so my initial reaction to these medicines that were coming out, that people were just getting these injections into their bellies, I was skeptical. And I
Mhm.
reached out to my best friend, Dr. Jason Breed, and I know he doesn't mind me shouting him out, who was a big fan of it. And that blew me away because Jason is very conservative. He's very health conscious. But like you, he kind of schooled me on obesity
Mhm.
and the disease state itself and how important it is. Well, during this program, the head person for Eli Lilly was on there, which I thought was bold, and
Sure.
started talking about the future.
Mhm.
And I always wondered how that would correlate with sleep. And yes, I'd heard there was a study out. So
Sure.
tell me about it.
Sure. So I think first, just give some lay of the land around these medications is really important
Yeah,
because
yeah.
I do think that currently the climate that we're seeing in regards to the use of these medications, number one is, oh, everyone just wants a fast fix.
Hmm.
The reality is, I do think it's really important to acknowledge that obesity is a medical state.
Hmm.
Right.
Yeah.
And that there are physiologic changes that occur, meaning that your body's chemistry does have differences.
Hmm.
And so for years, we've seen different medications, surgeries, diets, et cetera.
Lap band, lap
And
surgery. Yeah.
exactly.
Hmm.
And with the surgeries, part of the reason that those tend to be effective, especially when there is things like a Roux-en-Y, and these are more um, complex surgeries potentially,
Hmm.
where they're actually changing the size of the stomach. And part of that is because when you are having a state where eating becomes a maladaptive behavior, right?
Hmm.
So eating is necessary for us to
Right.
survive.
Hmm.
However, what drives that normally is brain signaling that's interacting with gut signaling.
Hmm.
It's doing this bidirectional thing, right? It's saying
Hmm.
like you should eat, and then the stomach's going, you're too full, stop eating, and the brain goes, you should stop doing that.
Hmm.
The reality is that normally we're doing that for survival. However, there is a reward pathway also that can potentially be triggered.
Right.
And GLP-1, which is one of the main components of these medications, they're GLP-1 receptor agonists. Zepbound Mounjaro, the drug from Eli Lilly, has GLP-1 plus another molecule called GIP. They're both agonists, meaning that they activate
Hmm.
this pathway.
Right.
These interact, GLP-1 interacts with another brain chemical called orexin. And orexin is one that is near and dear to my heart because of the fact that people who have narcolepsy are deficient or
Right.
can be deficient in this or have some sort of likely dysfunction in that pathway. What we know about orexin is really important, and not only in the feeding behaviors, but also the reward pathway. So it can be seen as a problem in addiction.
Hmm.
Now, with everything, there's a circadian expression
Hmm.
to how we utilize these different things. And so, even before talking about the use of these drugs, there have been really great studies done looking at how does people's bodies produce GLP, right? GLP-1 specifically. And what has been shown, and I want to show you this because I think
Sure.
it's fascinating to see and almost is counterintuitive for some. but it's giving you the circadian expression.
Okay.
This is the circadian expression
Mm-hmm.
of if I'm normal weight, overweight, or obese of GLP-1.
Mm-hmm.
GLP-1 is something that should be at a low level in your body, and then when you eat, gets activated.
Mm-hmm.
And that really is to help with the metabolism use. What you're seeing here is when I have a normal weight, you see that I have this low and then increase and low.
Mm-hmm.
And my level is somewhere between around 8 to 8.4, and at peak is 8.8. When I'm overweight, I have less of this fluctuation, and I live between 8.4 to 8.8.
Mm-hmm.
When I'm obese, I have almost no fluctuation of my GLP-1, and I'm living at basically a set point of 8.8 to 9.2. Okay. The reason this is important is because it's already setting the stage that my own body's GLP-1 is not being produced or utilized in the right way.
Right.
And so therefore, the mechanisms that it's supposed to impact are going to be dysfunctional. So now you bring along a medication that for me initially I'm going, this is so counterintuitive. If I'm already at a set level of GLP-1, why do I need an agonist of it? And it's probably because there's a dysfunction there. Now, with that stated, we know based on the data from Eli Lilly, from Novo Nordisk, GLP-1s are incredibly effective at weight loss and diabetes, right? Blood sugar control, and that's because of the pathways they take. Now, what is fascinating is that we now have this new era of study looking at obstructive sleep apnea. So we're going to discuss SURMOUNT-OSA 1 and SURMOUNT-OSA 2.
Okay.
What are these trials? These trials are looking at adults who have moderate to severe obstructive sleep apnea. Moderate to severe obstructive sleep apnea is diagnosis based on the criteria of the International Classification of Sleep Disorders, looking at the AHI, apnea-hypopnea index, and that's how many times an hour I'm having either a reduction in breathing with desaturation or arousal, or almost a complete stopping of breathing. And so this is for people who are having between 15 to 30 events or greater than 30 events an hour, right? And so we know that obstructive sleep apnea is not beneficial to anything in our bodies, right? It's associated with increased risk for a variety of deleterious outcomes. Now, when we're looking at this trial, what's important is in regards to this is that SURMOUNT-OSA 1 is looking at individuals who are on no PAP therapy. So I have moderate to severe obstructive sleep apnea. I'm not getting any treatment for it, right? So something is always better than nothing in that situation. When we're looking at SURMOUNT-OSA 2, this is looking at people who are on PAP therapy. And so is there any benefit? So before the study was done, right, did we know that weight loss was beneficial for obstructive sleep apnea?
Absolutely.
100%.
Absolutely.
And in fact, we would say with every 1% change in your weight, we will see a 2.6% change in AHI, okay? So having that framework already is important because one would say, is this all just driven by weight loss? And that's what we're seeing. Well, what we're seeing is that when we have people who are participating in SURMOUNT-OSA 1, they weren't experiencing weight loss to begin with. They weren't getting PAP therapy to begin with. They weren't getting anything that was actually treating, right? And so, again, anything is better than nothing. What did we see? Number one, we saw a very substantial improvement in the AHI. So these were people moderate to severe. The efficacy estimand results at 52 weeks. Now, estimand was, when I was initially looking at this, was a term that I needed to look up because I'm like, I've never seen a study that described, that described estimand. And at first I thought it was a typo. And I'm like, why are they giving me an estimate? Like, is it because the phase 2 data is so early that they don't have the full manuscript out?
First thing I thought of.
But it actually is a statistical analysis that allows for you to look at results that you know that there are going to be other contributors to change, right? And so that may be adherence, that may be things like weight loss, et cetera. For them, it really was looking at, were people actually utilizing us throughout? So they have the efficacy, but then they also have the treatment regimen estimand. And so that was including the analysis of people who even didn't complete the full 52 weeks. So what did we see? We saw the change in AHI was about 25 to 27, right? That is substantial.
That's
That
huge.
represented 50 to 55% reduction.
That's huge.
That's huge. Now, when we look at the weight loss, we're saying the weight loss is 17 to 18%.
Hmm.
That is more than that
1
1
to
to
2.6.
2.6,
Yeah.
right? So that's a really important factor because now we're seeing that we're not only making a difference in terms of the obstructive sleep apnea, we're making a difference in the weight.
Hmm.
And when we look at CPAP use, we see it can go in either direction.
It's true.
That people start CPAP, they can lose weight, but we also see people start CPAP and they can gain weight. When we're able to treat to potentially the cause for some people, and again, weight is not the cause for all people,
Right.
but for a person who has obstructive sleep apnea, who is already overweight or obese, treating the weight is treating at the cause.
I agree.
Okay? Now, at the end of the day, I always tell people obstructive sleep apnea is a neurologic disorder, right? And people are like, that doesn't make sense. It's a breathing problem.
Right.
And so, number one, there's nothing wrong with your lungs. You have obstructive sleep apnea. It's not a lung problem.
Right.
And although chronic intermittent hypoxia or dropping of oxygen can be a consequence, again, it's not the cause of it. When we see weight may actually change how easy it is for my airway to obstruct,
Absolutely.
right? For me to have that blocking. But we also know that you can have two people, both who are, let's say, 400 pounds. One person could have severe obstructive sleep apnea and the other doesn't have
That's
any,
right.
And that's because there are neurologic mechanisms that may be different there. And so the reason I bring that up is because everyone wants to focus on the fact that GLP-1 works on weight. However, it has peripheral and central effects. So peripheral meaning it works in the rest of my body, central meaning it works on my brain. And when it's looking at it peripherally or centrally, there again is this interaction with orexin. And orexin has also been demonstrated to be very, very influential in our wakefulness, as well as having a contribution to stability in breathing. And so I think some of the things that we're seeing here, yes, are related to the weight loss, but independent of that is related to the change in breathing stability. Now, we're seeing this substantial improvement in people with non-PAP therapy. This is a tremendous win.
It is.
Seeing a medication that is treating obstructive sleep apnea, not only treating at the cause, again, not the cause for all patients, but for patients who have issues with weight, overweight to obese, it is benefiting them. But that it also is giving another option as we're seeing this growing market of options, right? We have had PAP therapy, we have mandibular advancement device therapy, we have medications, we have surgeries, we have the hypoglossal nerve stimulators, we have the Excite OSA. So we have this expansion of options, and now we're able to treat more patients. So let's unpack those who were on PAP therapy. So this is the Surmount OSA 2. So in Surmount OSA 2, did they see the same benefit, right? They're already on. They're already on PAP therapy. Why give them another thing? Why? Because complementary medicine is always going to give us more ways to hit the target in multiple ways, right? So what did we see here? We saw the change in AHI, about 30. What did that represent? 58 to 63% reduction in AHI.
It's crazy.
That is substantial. And now what was the body weight change? About 20%. Again, we're seeing a greater degree of change in AHI than just body weight alone. Again, being able to impact body weight, being able to impact my obstructive sleep apnea, I now have hit 2 cardiovascular mitigators. I've now hit 2 diabetes mitigators. I now am treating the whole person in a way that is so substantial. And I think that this is going to be the gateway we see in regards to being able to better marry sleep across all of medicine. Because at the end of the day, sleep is the one process that we can all agree on that happens in every single person and reaches every single organ system in someone's body.
Again, I'm fascinated that this literally started with a show that Ash and I watched. I'm reaching out to you. This study comes out. I'm like, we got to break it down. And just such the benefits. So it has changed even kind of my perception of the pharma world coming into sleep. And so I'm very excited.
And you know what's interesting is that as we're looking at the current landscape of clinical practice, right? We are seeing there are a large amount of people who are on these medications. But let's break down whether or not that's a good or a bad thing.
Sure.
The most recent CDC statistics demonstrate that 75% of adults are overweight or obese.
That's crazy.
And when interviewed, at least 50% have said in the past year they've had an attempt at trying to lose weight, right? So we have people who are trying to fight the battle of a medical illness and have not been successful, right? We're now also seeing that people who are on these medications will describe things like, I don't even have interest in alcohol. And people are like, that's interesting. I guess that's related to the medication. That's the orexin effect. So we're seeing that by being able to utilize these medications in clinical practice, we're learning also of all the far-reaching ways we're able to treat the whole person and really help them to have more life-lasting benefit that is going to be hugely impactful. So I think it's going to be really exciting to see where companies like Novo Nordisk and Eli Lilly go with these, because again, recognizing that these are neuroactive, these are acting on the brain as well as in the periphery, on your pancreas and on your stomach and all these other areas. What are the other things that we're going to see benefited by utilizing these medications? I think there's a lot to be seen, and I think that some people have not the glass half full, but the glass half empty. What is going to be the risks? Those are going to be things that we also are going to learn. But at this point, I think the safety data has been favorable.
Tell you what, Dr. Ann, I'm so grateful for you to break this down. And for anybody listening or watching, you can like and subscribe to Sleeping Around the podcast. You've got to follow Damn Good Sleep. It's on all socials. So I appreciate you. And thank you very much.
Thanks. We're just keeping it between sleep friends.
We are.
Did this episode leave you wanting more? Then make sure you subscribe and check out this episode right here.